The Dr. Fazil TV Show is brought to you by POYA, People of Yuma Health Association. The Dr. Fazil TV Show is intended for health educational purposes only and complies with all the HIPAA regulations.
Good afternoon, everybody. Thank you for coming in. We're going to make it half an hour presentation. And then after that, as usual, you have, you can ask questions. You can ask questions during the presentation too. Either way is fine. I see some familiar faces and some new faces. So I might catch up with some old information so you guys get all on the same page. So there might be some repetition. Actually, there was supposed to be a person today who has lost weight through bypass surgery, not the heart bypass surgery, the gastric bypass surgery. So I asked her that if I could put her pictures inside the presentation, and she said, yeah, that's fine. So I was making my presentation last night, as usual, somewhere 3 in the morning, I guess. And I was trying to find some good pictures to give a demonstration. How does a weight loss surgery outcome, you can see their outcomes. And I remember her that there was one patient I sent to Phoenix because we tried everything, and you got to start with the diet and see how it goes. And if it works, that's fine. If not, then if there's a medical situation where you need to have the weight loss done, not for cosmetic reason, and people do for cosmetic reason all the time. I mean, we know that, right? But we were talking about medical weight loss. So as I was coming here, I saw her with her mom in one of the exam room. I said, hey, how are you doing today? She said, I'm doing great. How much? 150 pounds. I said, great. And I said, we want to take your pictures right now because I need some fresh content in my presentation. Everybody's saying it looks the same content as last year. So this time I said, okay, what I'm going to do, I'm going to give a gap of 5 months so everybody forget about what I said last time. But when I found her, I said, hey, let me take your picture real quick. I take to Renee's room. I said, take the pictures. While I'm seeing patient, which is getting a little upset because I'm getting late. But I got to do this thing, right? I took the pictures, and then I sent to Jairo, our producer here. I said, remove the old pictures and put the new one in there. So we'll show you that. So it was pretty awesome that how certain things can make difference in somebody's life, I can't give too much information because of the HIPAA thing, and we're going to talk about the privacy information and everything. So no names, but yeah, she have lost, a lot of medical conditions she used to have, and she's still losing weight. So generally, when you do the weight loss surgery, and we're going to talk about that in a few minutes, there are 5 different kinds which are most common out there. People keep losing weight without doing any efforts up to 24 months. After 24 months, body gets used to, it'll stop losing weight, and then you have to stay on the diet. So that's why one of the pre-qualification requirements for weight loss surgery is that they should have tried lifestyle change first, proof that they have done it. There's some effect of, they can control the diet, So what the weight loss surgery do is just fast forward your timeline. So they could have lost weight anyway, but when you do the weight loss surgery, instead of doing in, let's say, 3 years, you would do in 3 months. So that's the difference. So pretty much you reserve it for those people who have urgent medical needs to have weight loss done fast. It has side effects too, so we have to be careful. It's not our first choice to do the weight loss surgery because then everybody would just go for weight loss surgery. And again, it will fail in 24 months because you still have to follow the diet. So if you're not able to follow the diet in the first place, then is a just 2 years game. Then you're gonna start all over again. And the second thing is that one of the requirements for weight loss surgery is that you have to understand this thing, that you know what you're doing, right? So that's why when we send somebody for weight loss surgery, one of the requirement or evaluation is that sanity. You know what you guys doing? Actually, you have to see a psychiatrist. That's one of the requirements. So you have to do weight loss, medical weight loss, get a signature from the doctor saying, yeah, they're compliant, coming for the program, they lost weight, but it's not fast forward, it's not fast enough. And then they go to a surgeon, they do the medical clearance, like the heart is fine, they're not going to have a problem on the OR, in the OR, the heart is not going to stop, or they're going to have a stroke, like a medical clearance, and then the shrink comes in, and all know what the shrink is, right? Not who's going to make you shrink you, but it's going to check your brain, make sure it's fine, that you know what you're doing. That's kind of very weird for me to. I think it's just a roadblock. I think it's just kind of delay everything, just like anything else in the, just you got to see that person. He said, I don't think do you hear voices? Yeah, only when you're talking to me. Yes, I hear voices. I was going to say, I think he hear voices, or she hear voices. No, not clear. All right, so that was just a warm-up, kind of like get you started up, One of the requirements is also the BMI has to be more than 35. They tend not to do it for children because they think they're not there yet. So we did kind of subconsciously talked about the requirement for weight loss. Plus, you have to have a medical weight loss condition, which is due to the weight gain, like diabetes, sleep apnea, hypertension, those kind of things. So you cannot be. I actually saw a patient today, and she came in and she said, "I want to lose." I think she said 50 pounds, and I'm like, "You don't look that overweight to me. I asked her the weight. Weight was not entered into the system, so I entered the weight and found the BMI. And we're going to talk about the BMI. BMI stands for basal metabolic index. I'm sorry. It's a ratio between your. Body mass index is a ratio between your height and weight. So 25 is normal, 30 is overweight, and 35 to between 30 to 40 is obesity, and above 40 is morbid obesity. So I don't know if that makes any medical decision-making difference. I think it just makes you feel bad. Oh, my BMI is 36. Oh, my BMI is 37. Right? I think 30 is the kind of like stay below 30 and you're fine. And 25 to 30 is overweight. So 25 would be good if you can get it. So the medical weight loss starts when your BMI is above 30. Just remember that. In the surgery is only indicated if your BMI is 35 and more, plus one medical condition, as we discussed. So she said she did not have any medical condition. I said, that's going to be difficult for me to help you out because I cannot justify, it's not a cosmetic reason for weight loss. So I did kind of give her some tips, how much calories you need to take in, just try that at your home, see how it goes, and come to my seminar. And I don't see her in seminar, so it might be an ambush, actually. I don't know. All right, so let's go to the next slide. Today's date, before and after, but I'm going to show you the real before and after. This is just from so just few things. I have no financial incentive. This is like my day off kind of situation. I enjoy talking freely. I was trying to find my actually jacket, and I found it. My all jackets were missing last minute, so I had to find a scrubs, and I just put it on. Came in I thought, okay, anyways, summertime, so almost summer. I'll use my scrubs. So I have no financial relationship or incentive with any organization. So that's my disclaimer. Don't give away your information, medical information, because everything's being recorded, and we do put online for other people who are not here and they want to see at their homes. So we don't want you to be hacked. Don't give your, you can just ask your neighbor have that problem, or an imaginary person have a problem, instead of saying I have this problem. So that should be fine. So, and don't give your names, please. We have given this presentation different names in the past. End up just saying it Dr. Fazil Show because it's only me all the time here, so makes sense, right? So we are on the website, drfazilshow.com. So you can go on your different Android or laptop devices or computers. We are in the waiting rooms. I made sure that. So I'm sure you guys are sick of me now. So I can treat you. Yes. YouTube. And I'm also trying to print myself into the magazine. Oh, this is actually was the last minute picture actually. So this was taken in 2017. And there was some pictures which almost look the same on the left-hand side. This is the patient I was talking about. And then I saw her today, and this is, you can see the difference even from the side. Big difference, right? And I said, are you still working at the same place? She said, no, I don't have to. I said, okay, I understand what you're saying. So we have discussed this BMI concept, 25, 30, 35, 40, right? Those magic numbers. So 25 would be good, 30 is where we kick in, 35 where surgery kick in. So we discussed already that in our initial conversation or presentation, when do you qualify for medical, surgical, bariatric surgery? So bariatric surgery is the general name for surgery for weight loss. There are different kinds, and we're going to talk about that. What's good, what's bad, what the recommendation is, So you can make an informed decision, like if you have to do the surgery. So most common question asked, like, is the lap band is good for me, or sleeve is good for me, or bypass is good for me, or I think those are three common conditions people ask. So first thing is, if your BMI is not 35, please don't. Insurance wouldn't cover it. You can get it done in out of pocket though, but that would be in cosmetic. Some people go to Mexico, get it done. Some centers in Mexico do a good job, some don't. I don't know who does a good job or who don't, but I've seen a couple. I think the husband got it done from Mexico, and the wife got it from US, and the result from the other side of the fence was better for some reason, and not from here. So I think it depends where you go. So if you're going to go, for cosmetic reason, in a different country, doesn't have to be Mexico, could be any other country, Then just do your homework. Make sure you check out with somebody. I asked somebody went to the Mexico, and I asked like, where do you go in Mexico? She said, I got donuts. I said, how do you go there? I've never been to Mexico. And I'm scared actually. Although I look like Mexican, but I'm just I have a phobia, So I don't want to say anything, but so she said there's a pharmacy there. The name of the pharmacy is Phoenix Pharmacy. I said, they have Phoenix there? They said, no, the name of the pharmacy is Phoenix. Okay, so that's the Phoenix Pharmacy is good. She said, no, there's a Purple Pharmacy too. I said, is Purple is good or Phoenix is good? He said, I haven't checked the Purple yet, but I'll let you know the next time. So she gave me a task that the next time she comes in, I have to go to Mexico and give her the feedback. And I know she means it. One of my patients, actually. So she said, you park your car in the Q Casino, then you walk across, and then Renee was saying it, I think I overheard that you don't go in the night. And I don't know, I think what does she mean by that. So I said, well, what's happened in the night? The vampires came out or something, like you get zombie lives over. So anyway, so I have a few tips. Q Casino, Phoenix Pharmacy, don't go in the night, No, take your own water, actually. I wouldn't recommend. Actually, somebody asked me, it's the same person actually, that if they have to go to Mexico, what is the CDC guidelines for vaccination? I said, let's look it up. So we went on CDC guidelines, and they said typhoid and hepatitis A. That's all you need if you are going to Mexico for short term. Typhoid fever and hepatitis A. Both are foodborne, actually. Have you ever heard about typhus Mary? In the literature is typhus Mary. So 100 years ago, in England, there was a cook. She was going house to house and cooking food, and she has an infection, and she was spreading it. And I think her name was Mary. And then they find out it was the typhoid fever. They couldn't find out where was it coming from. They find the source, what is the common denominator. And everywhere who got it, she was aware she was cooking the food. So they called her typhus Mary. So just general knowledge, nothing you need to worry about. I think they got her, She's still there. Yeah, that's 100 years. I'm sure she's immune by now. So gastric banding surgery. So let's go to the picture so it's easy to understand. So this is the gastric band, the lab band. A lot of people ask what the band is. So what they're really doing is they actually laparoscopically, so they don't cut you open, they make little holes, go inside, put a little band, and it has a little circulation system. And they have a port under the skin, so they can actually adjust your pressure, and with either water or silicone, they can make it more tight or less tight, based on how your response is. If you're not losing weight, they can make it more tight. You don't behave, they're gonna cut it off total. So I said the next step would be staple your lips, It's the same effect. Food is not going in there. So it's not very popular anymore. It have a lot of side effects. So it can be removable. It's reversible. So if you don't have any good effects, you can ask them to take it out. We have patients actually. We have lab bands still in there, and they ask to be taken out or sent to be taken out. So you lose up to 45% of weight with this surgery. It's reversible. And let's talk about the side effect, nausea and vomiting. Actually, we have a patient. I remember a patient. I think we all like stories, right? Especially when they're true. No fake news. All right. So I got a couple, and the husband was brought to me on a wheelchair. The guy is 7 feet tall, but very skinny. And he's a school teacher, right? And he's still struggling to keep his job. I mean, obviously, it's important. We have to put the food on the table, but you have to eat it too. So he was from another doctor, not sent to me, but he just wanted to see if somebody else can help. So I did some blood tests, and he was pretty malnourished, very, very malnourished. And I said, well, before what happened, he said, he got a stenosis, a blockage between the junction of the stomach and the esophagus because he got a lab band done in the past. They took it out, and it's not going anywhere. He can't eat anything. So I said, okay, well, what we can do is have you go to the gastro guys and put a hole in your stomach and put a tube. We call it G tube or J tube, depending on which portion of the intestine is going to. He got that tube in, and we start to feed him with the injections, with big syringe, 100 ml, crush the food, push it in. So he started to get his nutrition back, and he started to regain the weight and everything. And that's important because you have to have your immunity system back before we can do anything else. So eventually we sent him back for balloon dilatation. They open up his, stenosis. And this time it didn't block back. We took away the tube. And one day I saw him. He stopped coming back to me. I said, okay, well, no worries. But I saw him one day walking around. I said, hey, how are you doing, my friend? He said, great. I'm a healthy man now. I said, that's very, very exciting for me to see somebody has totally came, from very, very bad shape to almost normal, healthy condition. So it was a complication of the lab band, which almost killed him. So we be very careful. Those things seem like innocent, but they can be very dangerous also. Then, few months later, his wife came in, who's also a school teacher, and she was having bleeding, and she's postmenopausal, so she complained of bleeding through her, what should I say, vagina. All right. Postmenopausal. I'm trying to make it simple English, right? So, and I said, listen, this is not normal. We got to have you see the gynecologist right away. And she happened to have cancer, but luckily, it was caught early enough, and they did appropriate surgery, and she was in full remission. So I was very glad. I said, okay, man, it worked out pretty good. But she did not have the lab band, actually. It was just a coincidence. Husband and wife both got sick, but both got better, and I'm glad they did. All right, so gastric bypass. So the gastric bypass is actually, I'm going to show you the picture. I think picture is easy to understand. So there are two things, a bypass and sleeve. So what the bypass is, you can see the left side is normal, like a normal stomach. If you see if I can make it work. All right, maybe I can come here. This is your food pipe. That's how the stomach looks like. That's small intestine. It's a different portion. First portion, second, and third. So that's how the normal anatomy is. And the picture on the other side, the food pipe is going straight into the small intestine. And it is bypassing the bigger portion of the stomach. So it's a very, very small portion where the food can be stored. It goes straight into your intestine. So there's two mechanisms here. One mechanism is that you're not eating enough. Second thing is you're not absorbing enough because you don't have enough time for the food to stay. It just passes right through you. So therefore, there's a complication associated with this surgery known as dumping syndrome. And the dumping syndrome means that you have severe diarrhea, malabsorption. We have seen some patients which have done the gastric bypass surgery, and they come with bloating, diarrhea, malnutrition, they're low in vitamins, iron deficiency, because nothing sticks around. Everything goes through your stool. So then you have to constantly monitor the electrolytes and replace them as part of our post-op care. So just watch out. If you're going for gastric bypass, ready for dumping syndrome. Okay. So gastric sleeve is getting more common. Again, I'm going to show you the picture. The concept is a little different. It stimulates, and you can see this is sleeve. They just make a sleeve out of it. So it's still going to go through the stomach, and then it's going to the small intestine, but size is a lot more smaller. So it's kind of like lab band situation, but it's internal. It's not where you put just a kind of choke your stomach. They actually cut it down, make a sleeve out of it. It's reversible too, so they can put it back together if we need to. So that's getting more common. The patient I showed you the picture, she actually had a gastric bypass surgery. So I asked why you had gastric bypass surgery when sleeve is most recommended. She said, I want to make sure that I lose weight. I want to get all the way in. I said, okay. Because some doctors are, they're comfortable or more trained in certain kind of surgeries, and some don't. And one of the biggest challenge we have, especially in Yuma, is that in the insurance issue, a lot of we have only one doctor. I think she does surgeries, and they don't take access. So it's always a challenge to have somebody who have access to find a doctor in state of Arizona, because you cannot cross the state line, who can do the appropriate surgery. It's not just your bypass surgery, it's every surgery, So we always have to, and we've been pretty lucky in that we have been trying to find, I think Renee, you found him? Yeah, she found him online. So yeah, he was pretty good, and he did the job, and we have a great success. So we know if we need to send somebody else who have access, we can send to that surgeon. We have found orthopedic surgeons. We have found urologists. We're trying to find out all the good doctors outside of Yuma now. So practicing medicine is not a single person job anymore. I mean, you could be a good doctor, but if your supporting staff is not good enough, or your specialists are not good enough, then we got a problem. So it's a teamwork. So we're always looking for resources so we can use them when we need to. And that's always the challenge in Yuma. So sometimes you have to go out of Yuma to get the job done. So we have done all kind of stuff. I think one patient had kidney cancer. Well, here's the thing is, another story time. Don't sleep. It's not the story where you go to sleep, right? And Christian knows that. I think when we talked to him, Christian's here. Moses is missing. We have another kidney associate. He was supposed to come in, and I think he's on his way. Anyway, so the gentleman came in. He said he got a tumor on his kidney diagnosed 2 years ago in Oregon, and I'm here to take care of that. And I got a little concerned. I said, 2 years ago? And how big was it? He said around 2 centimeters. And I'm like, why did you leave your doctor, or why did you not pursue it? He said, I didn't like my doctor. I said, well, that's fine, but this is cancer we're talking about. So he said, here's the CD, and you see it. And said, unfortunately, I'm not a radiologist. I wouldn't be able to read it. I mean, I would probably have to have a radiologist to read it, but I think we still have to do another CT scan to see where we are now. My concern was it's not spread yet, because it's going to be totally different ball game. While I open up the CD, the case, a report dropped on the floor, and it has report of his cancer. And exactly, it was around 2 centimeters and was localized at 2 years ago. So we did a CAT scan. It has gone to like 4 centimeters. It was ready to pop, but didn't pop. And so we immediately sent it to Scripps, because most urologists here, they don't do those kind of surgeries. We have some connections there, good friends. So he said he does not have secondary. I said, yeah, I understand. So do you have a trash can? He said, yes. I said, when the bill comes in, just throw in the trash can. You're going to be fine. It's better that way versus have a good score and being dead versus a bad score and being alive, Sometimes you have to make a judgment call. I don't know if it's legal to say that or not. I have to say that, actually. It seemed fun, So anyway, he got surgery done, and luckily cancer didn't spread, and so that was a good thing, So I have sometimes you have good outcome, some you have bad outcome. You have heard about second opinion, right? Second opinions. Have you heard about third opinions? Lately we've been doing the third opinions. Yes. I have actually a patient saw yesterday. Got and I'm not taking any names because of not getting into slandering thing and stuff, but you know what I'm saying, right? So the patient was sent for stent placement in the legs, and they used the radial artery, like artery in the arms, to to put the stent into the leg. That's how they do it nowadays. Patient came to me and he showed me his hand. He was due for annual physical exam. So when you do the annual physical exam, you do a lot of things. You do like, bone density, this and that. But I said, listen, I think we can wait on those things because I think what you got now is a little bit more urgent. So we can talk about other things later. And his skin, he already had an amputation of the toes because of poor circulation of the left side. Right side. And then his right hand was also swollen and I couldn't feel any pulse in his hand. So I knew that the artery was blocked, whatever happened was a complication. So I said, okay, he said, I went to second doctor and this, and he said, whatever. And he was flown to another place in Phoenix immediately when he showed his picture on his phone to somebody who did the surgery. And they got really nervous and they said, no, you need to fly to Phoenix. And he said, I can drive. No, he said, no, you got to fly to Phoenix. So they flew him to Phoenix. The surgeon there, he said, oh, all you need is a good dinner. I said, seriously? That's my second opinion, just good dinner. I didn't know that. So send him back to me. I'm looking at his hand. I said, dinner didn't help you. I mean, I don't know what does that mean. So we got to get the third opinion. So I knew a guy who used to work for us in the past, and he had moved to Phoenix. He's a good interventional radiologist. So I said, let me call him. Now my phone was dead, and I have to charge it. I was behind on my schedule. So I put on the phone my charge, and I'm trying to do TLC, tender loving care for the patient, so nobody get mad with me. I'm behind on my schedule. I want to come on, man, phone get charged, so I can pull up his number. So I call him. Phone get charged, and there's no number inside. I said, okay. I went to my email, searched his resume, and called him. And he didn't pick up the phone. I texted him. Then he called me. And then he said, oh, yeah, I told him the situation. And he said, send to this doctor. I said, no, that's what happened. He said, the word started with the D. Oh, yeah, you're right. He's the D, I said, you're on the speakerphone. Patient is hearing it. Patient said, no, I agree with it. That's fine. There's no worries. So next day, for the third opinion, I said, no, you don't have to fly. You can drive. Just go to this doctor. They're going to do they have to declot your artery so you don't lose your hand. You can have a gangrene of your hand. You can lose your hand. You're right-handed, and it's going to be a problem. But I was glad all those efforts, my charging my cell phone and searching my email worked out, and I was a little behind, but I think you're all used to it now. There's a reason behind it. All right. Duodenal switch. Seems like you're taking somebody else's duodenum and putting in yourself. That's not what it is. It's actually a very complicated surgery. So it's a kind of like combination of a gastric sleeve and a bypass. It's kind of, they combined both, so they're using a portion of the stomach and then they're also bypassing it at the same. So it's more intense surgery, more drastic results, but more complications too. So it's not commonly done. So we are between, if you have to talk about the surgeries, then there are only two, sleeve and bypass. You have to pick one, go for sleeve. That's it, simple stuff. The last one, I know you're all hungry now, electric implant. So you can actually, just like a pacemaker, you can put an implant inside the stomach, and what it does is there's a nerve inside the inside the stomach known as vagus nerve. It stimulates that. When it gets stimulated, you feel hungry. You feel full. So the brain says, okay, I'm full. I don't have to eat anything. So you don't eat and you lose weight. So that's another less invasive way to lose weight. So electric implant. Most patients after weight loss surgery lose weight for up to 18 to 24 months. Then they start to regain if they don't watch their calories. Therefore, you have to watch your calories. We talk about the dumping syndrome. If you get a gastric bypass, you're probably going to get dumping syndrome like that, malabsorption, diarrhea. Also, people who have those surgeries, they tend to have more episodes of gallstone episodes. If your gallbladder is already taken out, then don't worry about it. And we just talked about that. And then malnutrition. So people who have surgeries, we have to monitor their vitamin B12, iron, and replace it accordingly because of manual absorption. So those are three complications. Now you're ready for your boards. You pass exams. You're all surgeon now. And I think we covered all the basic important stuff for this topic. Okay, guys, thank you so much, and appreciate your coming in.